Hi, so my name's Amanda Lee, and what I'm going to try and talk to you about first of all is just a little bit about my own research, just to give you an idea about how other people use research in their practice. I'm also going to try and explore how we find evidence which supports our work as nurses or healthcare workers. I'm also going to try and identify some of the centres of research excellence that we do find in nursing or allied health professionals to support our practice, and the way that we can use those to sift through the massive amount of information and all of the evidence that's out there. I'm then going to consider evidence-based practice and what actually this means to your profession. I'm going to introduce the Prisma, which is a systematic tool which reviews, analyses and presents how we've looked at the literature. So it gives you this systematic process which underpins what you're doing and how you've actually searched for the literature in your search strategy. And I'm also going to identify how we all, in our own professions, cannot believe everything that we read in peer-reviewed journals. We can't just take research as a given if it's published in particular peer-reviewed journals. Hope that's okay. Hope you enjoy the lecture. So I'll give you a bit of an overview of my particular research. I'm studying gastroesophageal cancer. The reason for this is because gastroesophageal cancers are the 8th most common malignancy in the world. There's a stark geographical belt with a higher incidence across Asia, Middle East and Europe. Patients are often over 65, they're males from lower socioeconomic backgrounds. Many of them present at very advanced stages, meaning the survival's really, really poor. These set of circumstances give me a unique platform to evaluate whether mapping patient and population characteristics might predict the geographical areas where there's higher incidence. That evidence is going to inform geographically targeted health promotion and intervention strategies, which might encourage earlier presentation. So what I'm doing is a case study, and what I'm doing in my case study is applying descriptive and geographical analysis for a 10-year cohort of gastroesophageal cancer patients. I'm analysing and displaying the data using a geographical information system which enables me to map these findings and present them in an easy format to my peers and people who may find it useful. I'm trying to integrate the 4 pillars of geography, so I'm looking at person, place, space and time, and how they link with the gastroesophageal cancer cohort in and around this region. So what I'm trying to do is identify any areas where there's increased density gastroesophageal cancer which aren't explained through the population descriptors, so the underlying populations. What I'm doing is cluster analysis to see if there's any sort of things that we can target information and interventions with. The reason why I'm doing this is because geographical analysis of data can be useful in the prediction of disease incidence. If I can find something at small scale which can be used to really inform what we're trying to do, then that's my PhD, that's exactly what I'm trying to do. So what I'm trying to do is engage in an in-depth analysis and evaluation of the disease processes which are associated with gastroesophageal cancers. It's really exciting, and it just shows me as a new and emerging researcher how I can really use research to inform and underpin evidence and practice. Okay, so this is a slide that I use in class, and what I try and do with the students who are sitting in the classroom is start to think about where they work and how they manage to provide evidence-based practice or rationales for what they're doing. I get them to go into groups of 4 and have a real think about what sort of situations or scenarios that they've just recently met. Think about how they want to sort of form a bit of a research question or find out a little bit more about the services that they've met. Try and think about what methodologies might underpin that. And we're not just talking quantitative or qualitative, but for example, if you're an advanced practitioner, you might want to try and find out what it's like, how it feels for other advanced practitioners to move and merge into a new role. Given that sort of thing, you're trying to find the feelings and the essence of. So what you're trying to do there is you're trying to really merge. So the idea, the research framework that you might choose to do would be a phenomenological approach which seeks to sort of really unpick the essence. And the reason why I get the students to do this sort of thing is because then we can start to look at not just the fact that research is quantitative or qualitative, but underneath that quantitative or qualitative, or even mixed methods where you choose a bit of both, you can really use the tools within the research to start to unpick the essence of what is going on in that particular question or in that area, and how on earth you can actually identify and address that situation. This slide is basically, it was a nice research project which identified things that stop us from being able to change practice. You know, not knowing the evidence, not knowing how we can use evidence to impact what we're trying to do and how we're trying to change things. There tends to be a lack of motivation out there. We're all busy on the wards, we're all busy out in the communities and wherever else we're working, and there is no way that you have time to be able to sift through the massive amount of information that we talked about before. The other thing as well that can stop us from wanting to become evidence-based practitioners and change agents is the fact that change might not benefit patients. Yeah, okay, we've all identified that this is a great way to implement a stop smoking strategy. However, I'm working all right and my patients are stopping smoking if I do X, Y and Z. We've always done it that way. Have you all heard these ones before? The other thing that's identified as well was sort of the fact that a lot of people are reticent in looking at evidence and having a sift through the research because they don't think they've got the research capabilities to be able to do it. Practically, we have difficulties in trying to resource and staff manage time and continuity of care and all that sort of stuff. There's no way that during a busy shift you'd then be able to pop off and grab the best evidence to support what you're trying to do next. There's also a lot of external environment stuff as well, you know, the managers not giving you resources to continue to update and study, all that sort of stuff. And these things were all highlighted in a study by NICE in 2007 as barriers to you trying to adopt evidence-based practice. So the last slide sounded quite easy, didn't it, really? But it's not. I mean, we all know, and the reason why I choose this picture to have a look at on this slide is because there's absolute wealth of information out there. How on earth can we start to identify what information is suitable, is applicable to our own particular demographic of our clients that we have, and really what research is good, what research is bad, what evidence is good, what evidence is bad? How can we start to really unpick what's out there? Well, the nice thing that we have in healthcare is that we have these lovely centres of excellence, or these sort of wonderful places that are there to unpick all of that massive, great big amount of information. So we have a Cochrane or a Joanna Briggs Institute, and what they do is they just review systematically all the evidence that's out there and produce some information based on the systematic review of the evidence, which will guide us in our journeys to deliver healthcare in some way, shape or form. We also have these expert advisory groups like the Royal College of Physicians, the gastroesophageal cancer groups, the advanced presentation cancer groups, so the early diagnosis groups, and then we also have our clinical journals, which supposedly are peer reviewed by a group of reviewers, and are there to set some standards in publication of reasonable evidence which is affiliated with the information and the evidence upon which we can support our practice. Now, these are all really great. The reviews of evidence to support our practice, so the collaborative groups who are analysing the resources that we have, that's great, but it can only ever be limited by the resources that are there in the first place. The expert advisory groups, who are the experts? Do they have nurses, physios, all the other range of groups that we find? Are they adequately represented in these particular expert advisory groups? Do they capture the elements of what we need for our particular patients? And then the clinical journals, who are the reviewers? Is there any publication bias? Is there anybody there within these clinical journals that are methodological experts in every single paper that they're publishing? How's the impact factor of the journals actually going to try and affect what they publish and how they publish? Are there any issues there? We're all told that we have to base our practice in the best possible evidence. why do we need to do that? It's not just about basing it on best possible evidence, it's about trying to grow as yourself as an evidence-based practitioner. So one of the reasons why I've used this slide, and I'm very sorry to non-nurses, but this is just, this was the only thing that I could find which sort of identifies what evidence-based people look like or how they are. So what you're trying to do, and one thing that I've learned through the process of research, is just about self-questioning. Identifying that I don't have all the answers, and it's okay not to have all the answers. It's about dealing with problems and situations that come up and dealing them in a reflexive type of framework. So one set of how I manage a patient who's presenting with a cardiac arrest, for example, will inform how I manage a patient with a completely unrelated set of issues. But I'll use some techniques from one set of issues to another, and that's called heuristics. And what we do as researchers and evidence-based practitioners is to really start to build on our heuristics and start to make these little leaps of faith, as it were, from one thing to another to inform our practice. So this slide it sort of builds on the last one with the what makes an evidence-based person. And what I wanted to really identify here is that we've all got our own wisdom, we've all got our own heuristics. You can read whatever you want to, and certainly, let's take being a parent for example. I'm a parent, I read all the books, the Dr. Spocks up to the Miriam Stoppards and all those sorts of things on how to help a baby to try and sleep at night. Nothing worked in any way, shape or form. But what I did was I used my own feelings, my own heuristics, what worked best for me. So I gathered all the evidence from everybody else and what they were saying, and then applied what worked best for me in my own context. And that's basically what you're expected to do as clinicians. It's you that's at the interface, it's you that's sitting with the diverse array of, for example, socioeconomic groups of patients that you do meet, or customers that you meet in your sort of everyday life. And what you've got to do is weigh alongside what evidence is supposed best practice against what evidence works well for you as well. So the good thing about this is that you can then start to reflect on everything. And when you've finished your day and you've thought about how you've approached your decision making or your way forward with your patients or your customers, that when you're thinking about that sort of thing, you can start to really reflect. What works best? What evidence am I using to base that on? Why did I make that decision? Why did I make that choice? Am I basing it on gut instinct? If so, where's the gut instinct come from? Has that gut instinct arisen from the amount of research or learning that I've engaged in the past few months? You're all here on a course, which means that you are actively engaged in trying to better yourself and trying to make yourself more educated, which is fabulous. And what that shows is that you're looking to build your own wisdom. So you're building a set of heuristics which will inform your decision making, your practice, and your ways to deal with the situations that you're going to meet in the future. What I'm offering here is just some hyperlinks to some really brilliant systematic review centres for evidence that I found along my journey. And what they do is, I would sort of suggest that what you need to do is just have a double click on each of the hyperlinks. They all do work, or they did certainly when I recorded this, which was in 2015 November. But what you'll find is the more you start to engage with these areas and the more you start to look at these systematic review centres, the faster you can access really relevant information which will inform your own practice. So have a go. The MHRA is quite difficult to navigate to start with, but once you get used to it you'll find it that's okay. I love Joanna Briggs Institute, again that's my Australian sort of background, but equally there's the Cochrane and the York Centre for Diseases databases, which are excellent. But what they also do is show you how to systematically evaluate evidence. They provide these beautiful frameworks and provide the gold standard of how we should be looking at evidence in a documented format. So I've spoken about the centres of evidence, and what they do is they basically provide a systematic review of all the evidence that's around. So they merge all the data from lots of studies in order to answer a clinical issue or a clinical question. So the concept of that is they'll grab all the studies. The systematic review process will be there to systematise all of the data that's available, or merge all of the qualitative data, put it into some sort of reasonable order, and then produce an output. Now, 75 studies with 5 subjects each, put those all together, if you've got a nice reasonable framework, will produce a significant study with a statistically significant outcome, whereas each study may not individually give you what you need. So systematically reviewing is actually a process, it's a research process in itself, which is there to be able to look at how the research was completed, how you can merge the data in a reasonable format, and how you can evaluate that data in the context of the scenario that you're looking to research. But before you even start the systematic review, you have to find the information to start with. So how do you find that? And this again is something that comes with a systematic process. I'm not sure if anybody's seen the Prisma flow diagram before, but it's a great thing to really define how you found your papers, how you find your research. Because what it does is it shows that you have not just had a go on CINAHL and Medline and whatever else, but you have systematically followed a process by which you have discovered information and evidence pertaining to your particular research question. So first of all, it starts off with identifying the amount of records that you've done. So you'd probably say you started off with a search of CINAHL, Medline, etc., etc., and you have identified X number of records. Then you start screening those. So you start to remove duplicates, you start to remove things that are too old, too out of date, have been removed within the evidence sort of based literature, whatever else. And you'll identify how many records you screened then. And then you'll have a look to see if anything's eligible. So you start looking at that and you start thinking, okay, right, let's have a look at the abstracts and identify whether or not full texts are available and everything, and whether or not the rigour of the research has been appropriate enough for you to include within your systematic review of evidence. Then you identify a couple of studies, and then you'll start to really synthesise all the information within that process. So then, once you've done all that lot, then you can start on a literature review. So the Prisma flow diagram is there to underpin any literature review that you ever do in the future. So for those of you who are going on to complete your masters, you will really benefit from having a work through a Prisma flow diagram, and have a look at a lot of the really good seminal works in the literature that you're reading at the moment, and see how they managed to organise the review of the literature which underpinned their initial research project. Have they gone through this Prisma statement? Have they identified what studies they excluded? Have they identified why they excluded them? What's going on? The other thing the Prisma's flow diagram does for you as well is it gives you a brilliant process by which you can just completely follow that too. So for example, if you had some seminal work and you identified it and it was published in 2010, what's to stop you from doing just the same process in 2015 and updating that? These sorts of things are all the processes that we try and do to underpin our research, and these are the gold standard sort of ways forwards. There's a hyperlink there to the Prisma statement, and you're more than welcome to access that and see if you can find anything else about that. So this all sounds absolutely brilliant, doesn't it? So we need to systematically review all the evidence to be able to produce something that we can base our work on. We need to undertake a complete and utter meta-analysis before we do anything at all, so that we are evidence-based practitioners. In the real life, it really doesn't work like that. There is no way that we can do a research project at every touch and turn to answer every single research question that pops up when we're being clinicians. All we can do is to try and pinpoint the precise nature of what we can reasonably expect is reasonable evidence which will appropriate what we're trying to do. We do have a big reliance on these journal editors, and these journal editors are these supposed experts who will help us. Peer review process is there supposedly to make us be able to rely on what's been published in the nursing or the medical or whatever else literature out there. but we can't necessarily rely on those because at times they're not necessarily right. When I submit a paper for publication, it goes to the journal, and then a number of peer reviewers will look at my paper for publication, and then once they've done that, they'll send me a load of corrections that I have to do so that it fits in with the publication standards, and you amend those things, you send it back, and you might get some more things to amend, and then it comes back and forth and back and forth. However, the most important part is that peer review process. So my paper, my research, would be assessed by a number of researchers with expertise in those areas, hopefully, who can then provide feedback. Now, there's a couple of issues with that. Peer reviewers tend to have their own methodological processes, their own methodologies that they like. Papers, journals, have particular biases that they like to fulfill. So, for example, the Journal of Nursing Management will prefer to publish articles which will be management or leadership associated. The other problem is that if you do some research and your research proves doesn't prove the null hypothesis, so therefore it is negative, then are you really going to get that published? Does everybody want to start going, whee, we discovered that heart disease isn't linked with, I don't know, eating grapes? You're not going to get that type of paper published because people don't want to. It really doesn't say anything. Ben Goldacre is coming on next, and I'll get you to have a look at his explanation of the limited reporting of negative results, how that really results in some really skewed reporting in, for example, the pharmacological evidence that we use. The other bias that we also have is the fact that most of our studies, most of our searches and everything else is limited to the English language. Now, I've had affiliations with Chinese researchers for a number of years, and I have never, ever, ever systematically searched a Chinese literature. However, I was very, very fortunate to work with a student who did just that, and she searched one of the Chinese databases for evidence on gastroesophageal cancer, and it completely opened my eyes to this wealth of evidence and literature that I have very, very limited knowledge of because it's published only in the Chinese language. Now, most of these countries are now publishing in English language, in the English language journals, but what does that mean for that wealth of literature that's still out there in the Chinese journals? And I'm just using China as an example because it was one of my students that did that. Same goes for India, same goes for Arabic countries, everywhere else. Are we only really exposing ourselves to the literature that's out there in the UK language? If so, how does that bias our results? This man in 14 minutes will really, really, really capture exactly what I'm trying to say. He is absolutely fabulous. He's a medic, he's an epidemiologist, and he works a lot to expose and uncover the issues that are associated with evidence-based practice in medicine and healthcare. I would really strongly advise that you try and access this TED lecture and many of the other TED lectures that are available, which will really, really unpick and open your eyes as far as evidence-based practice is concerned. For those of you who can't quite manage to get onto the hyperlink, I've actually also included the annotated component of his talk. So please have a read of it, it's brilliant. And now you've heard Ben Goldacre going on and talking about evidence-based practice. Do you believe anything that you read ever again? Are you going to question what you're doing and what you're reading? This whole research and evidence applied to practice module is there to get you to really, really question what you're reading. One of the reasons why we get you to choose a particular research article is so that you can just have a little go at that Prisma process that we've talked about so far. One of the reasons we get you to critically analyse your particular chosen piece of research is to really get you to do what I've tried to do today, which is to question the very assumptions that are made in each and every single research paper. One thing that I would say is research is hard, it is not easy, and the more you dig, the more questions you answer, the more questions you get. the harder you realise it is to unpick the dogma of information and resources that are out there. So, you know, all we've got so far are the wealth of academic journals that we can use to be able to inform our practice. Reasonably, all we can expect to do is to try and get the best possible stuff which will inform our practice. Seriously, it's just about weighting what we've got to work with. I've got some more articles on the next slide which will just help you out a bit more about evidence-based medicine and evidence-based practice. Feel free to access them, and I hope you've enjoyed the lecture. Take care.